Okay, everyone, we're going to go ahead and get started. Welcome to All You Need to Know About Rotator Cuff Tears with Dr. Siddhant Mehta. Just a quick note before we begin the presentation. Please hold your questions until the end of the presentation. You may use the chat box or the Q&A when asking your questions, either or. I would like to start by thanking Hackensack Meridian Palisades Medical Center, Nikki Medeiros, and Dr. Mehta for generously donating their time to organize and appear at this event. We greatly appreciate you guys being here. Dr. Siddhant Mehta is a board-eligible fellowship-trained orthopedic surgeon at Hackensack University Medical Center and Palisades Medical Center. Prior to joining the orthopedic group at Hackensack, Dr. Mehta completed his American Shoulder and Elbow Surgeons Accredited Specialty Fellowship training at Washington University School of Medicine in St. Louis, Missouri. During this time, he served as a clinical instructor of orthopedic surgery and treated all conditions of the shoulder and elbow, including degenerate, sport-related, and traumatic problems. Dr. Mehta also has extensive training in conducting orthopedic research and obtained a PhD degree and postdoctoral training at the University of Mississippi Medical Center. Having been born and raised in Bergen County, Dr. Mehta is excited to return to New Jersey and treat the community which he grew up in. He aims to provide the highest quality, evidence-based care to his patients and not only educate them on their musculoskeletal conditions, but also discuss and develop the least invasive treatment strategy with their valued input. If surgical treatment becomes necessary, Dr. Mehta is well-trained in minimally invasive, arthroscopic, and open surgical techniques to help restore function, improve quality of life, and return his patients back to the activities that they love. So without further ado, I'd like to introduce Dr. Mehta.
Thank you for that extensive introduction. I appreciate that. So let me go ahead and share my screen here. Are you able to see that?
Yes, we can see that.
Okay. Well, so thank you everyone for joining us tonight. I'd like to speak to you all about something that's very common, and it's something I see on a daily basis in my office, and it's probably something that at some point in our lifetimes we will have some sort of problems with. So it's good to be educated about it. And that's kind of my goal of this talk tonight. I'd like to, go through really just briefly, just introduce myself. I'm part of the hospital employed orthopedic surgery group at Hackensack. And through that, I work both at Hackensack University Medical Center as well as Palisades Medical Center. And these are other members in our department. Dr. Kelly is our chairman. Dr. Yair Kissen, who's a knee specialist. He does knee and hip, knee replacements and knee arthroscopy. He's the vice chairman. Myself, Dr. Amit Merchant is our pediatric orthopedist. Dr. Fran Patterson and Dr. Lelkis, who recently joined, are our orthopedic oncology specialists. And Dr. Stephen Rossman, who is our hip and knee reconstruction specialist, who does hip and knee replacements here at Hackensack as well as Palisades. Just a little bit about myself. I actually grew up locally in Fairview. I went to Lincoln School and ended up going to Cliffside Park High School. And I've been all throughout the world for my education, both in Europe as well as in the Caribbean. And I ended up in a totally different country in Mississippi, where I did my residency training. And then finally at the Washington University in St. Louis. So I bring to you my expertise as I've learned under some of the greatest surgeons, as well as through my own patients. And so here we go. Objectives of tonight's talk, I want to talk to you basically, I'll give you some basics about an introduction of shoulder problems, talk to you about the anatomy so you understand where we fit into, where rotator cuff disease fits in with respect to shoulder anatomy, discuss some of the signs and symptoms, and then talk about how I would diagnose rotator cuff disease and talk about some treatment options. So shoulder pain is a very common problem. It ranks really second only to low back pain as a common cause of musculoskeletal disease. It's often age-related. So in younger patients, more commonly seen as instability and labral tears. And as we grow older, starting in the middle age, rotator cuff disease becomes more common. But in addition to rotator cuff problems, there's also something called adhesive capsulitis, which is frozen shoulder, as well as acromioclavicular joint arthritis, AC arthritis. And then as we progress past, the 60s to the 70s and onward, more commonly, we encounter arthritis of the glenohumeral joint, also known as, the glenohumeral joint is the shoulder joint. And then as we get older, also, if we sustain a fall, you can injure the shoulder, including the rotator cuff, but also fractures in the shoulder. So tonight, our focus will be on rotator cuff problems in both kind of middle age and elderly patients. So a basic review or overview, I should say, of anatomy of the shoulder. So the shoulder has several bones. One of them is the scapula, which is commonly known as the shoulder blade. The other is the collarbone that sits in the front of the shoulder. And then the humerus, which is composed of the ball. The shoulder is a ball and socket joint. So the ball part of the humerus is the humeral head. And it connects to the humeral shaft. And then the socket is actually a part of the shoulder blade known as the glenoid. And so through the glenohumeral articulation, that's what we know as the shoulder joint. This is a representation of some of the anatomical structures that are important in kind of understanding for me as a clinician, but also for patients that I go through once I am seeing patients to help better educate them about their problem. So again, we talked about the ball and socket joint, but around the shoulder, there's a group of ligaments that make up a capsule. It's the superior, middle, and inferior glenohumeral ligaments. You have the long head of the biceps that runs in the front of the shoulder. You have quite a number of ligaments that are important. And then this is another more simplified version of that. So this is the capsule that's made up of these ligaments and the long head of the biceps coming here. And as we go deeper, we can see the shoulder, the socket. If we took this view and rotated it in this plane and looked at it en face, we can see that the socket is a pear-shaped structure that's lined with a thick layer of cartilage known as the labrum. And surrounding that is the capsule as well as the tendons of the rotator cuff. So these are the people talk about rotator cuff. Oh, I have a rotator cuff tear, but very few people know that the rotator cuff is actually a group of muscles. There's actually 4 separate muscles that are important in providing not only stability of the shoulder as you're moving your shoulder, that we call that dynamic stability, but also allows your shoulder to move in certain directions. So there's one tendon on top. This representation is looking at the shoulder from the back. So this tendon coming on the top is the supraspinatus tendon. Then this is the infraspinatus. And as we go further back, this is the teres minor. And then if we look at the front of the shoulder, there's one major tendon unit called the subscapularis tendon that is the front rotator cuff muscle. And so these tendons work together to stabilize the shoulder. And if there's a tear in one of these tendons, it kind of throws off the entire force couple of the shoulder, which changes dramatically the biomechanics of the shoulder, which is what leads to a lot of the problems that we see in patients. Now, this is another representation of the rotator cuff, and here what's portrayed is the subacromial bursa. A lot of patients hear about, oh, my doctor thinks it's bursitis. So bursitis is inflammation of this little cushion that sits on top of the rotator cuff. And when it gets inflamed, or when the rotator cuff is inflamed, it translates to some of these symptoms. And rotator cuff disease is quite a spectrum of disease. It's not necessarily a rotator cuff tear, or there's a continuum of disease. So the less severe, rather reversible changes are edema and inflammation of the cuff. and the bursa, which are known as tendinitis, bursitis, or you might have heard of impingement. And then as we progress to scarring and fibrosis of those tissues, as well as degeneration, tendinopathy and tendinosis is what you might see on an MRI report. And then finally, when the tendon fibers have weakened to a point where they tear, then we see partial, there's tears of the rotator cuff, which can be classified as partial thickness tears or full thickness tears. And I'll go a little bit more into that in the next few slides. So this is a representation of a normal shoulder where there's no inflammation of the bursa or the tendons. And here we see a representation of inflammation involving the tendon of the rotator cuff, as well as the bursa there. This is an example of an inflamed bursa, which would lead to significant pain in the shoulder. And here we see a representation of tearing of the rotator cuff. And what you can see here is that there's partial tearing, not full thickness tearing. That's better assessed on this. So this shows us the ball and the socket joint and the rotator cuff tendons coming in from the top. Okay. Normally, this is in full continuity. And when we talk about tears, especially partial thickness tears, we're really referring to the thickness of the tendon that's involved. So if we say from this point, as I'm pointing on the screen here, from this point to this point is the full thickness of that tendon. And if a part of that tendon is involved, we call that a partial thickness tear. And partial thickness tears occur either on the top of the tendon or on the bottom of the tendon. The top of the tendon, as I mentioned to you, is the side where the bursa is. So that's called a bursal sided tear, partial thickness tear. The side underneath the rotator cuff is where the joint of the shoulder is. And when we talk about joints, we talk about articular sides or the articular surface. So tears that involve the undersurface of the tendon are the articular sided tear. So if you're reading if you got an MRI recently and you see a partial thickness tear of the bursa on the bursal side of the tendon, that's what this representation is. And articular sided or undersurface tears is what this looks like. And this is just another drawings demonstrating that. So another picture here showing what the rotator cuff normally looks like in the perspective in a real live patient where we're only drawing out this part. So this is looking at the shoulder from the top, and there's different parts of the bony anatomy here, but the rotator cuff muscle is here. And as it comes down to the side of the shoulder, it becomes a tendon. And this is where the tendon commonly tears. This is, back maybe about 10 to 15 years, the standard of care for rotator cuff tears was to do an open or mini open procedure. Now we can do this with advances in technology. We can do the surgery arthroscopically in a very efficient manner, but this used to be the way to do it. And this is just kind of a representation of what the rotator cuff tear looks like on gross inspection, and the schematic that goes with that view where these tendons are coming in. Here now there's a tear where the tendon tears off of where the normal bony attachment of the tendon is. So just some basic facts about rotator cuff problems. So, so you can have pain in your shoulder even if your rotator cuff is intact, and so both the rotator cuff intact and torn states can be painful. The most common tendon that's affected is the supraspinatus, and it's a very common problem. 7 to 40% of patients, or in certain studies, cadaveric studies on cadavers that have been opened up for whatever purpose, they documented 7 to 40% prevalence of rotator cuff disease. And we see rotator cuff problems in an age-related fashion. So as we get older, the tendon quality diminishes, and the incidence or prevalence of rotator cuff disease increases. There's actually, this is a very interesting fact, that 28% of patients over the age of 65 have a full thickness tear. And we're not talking about symptomatic patients. So these are patients that have no pain. Almost 30% of patients over the age of 65 have a full thickness tear that doesn't bother them. So that goes to show not all tears of the rotator cuff need surgery. Not all tears are symptomatic. But when it does start becoming inflamed, that's when the symptoms appear, which may need further treatment. So another fact, pain in one shoulder, there's a greater than 50% chance that there is a rotator cuff tear in the opposite side after age 66. And these basic science or natural history studies were done mostly at the place that I trained for fellowship at WashU. And so I trained under the gurus that wrote kind of the research on rotator cuff disease. So it's interesting perspective that I was exposed to. So signs and symptoms of shoulder, a rotator cuff problem. So rotator cuff based pain is commonly described by patients as activity related pain, particularly when they're raising their arm overhead or reaching out to the side or reaching behind the back. Females commonly complain that, they can't reach behind the back high enough to get to their bra. A lot of males will complain that they can't, get to perform, personal hygiene to reach behind the back. So those are common activities that patients complain about. Can't get to their hair, can't reach the back of their head. And these are all kind of triggers for me to think about rotator cuff problems. The pain that patients describe is also commonly that occurs at rest and at night. For whatever reason, a rotator cuff disease, the pain that's associated with rotator cuff problems is very problematic at night. And in certain circumstances where there's a large tear, there's weakness of the shoulder. So certain muscles are weak, the rotator cuff muscle, where certain motions cannot be performed. On physical exam, most patients that have these problems have a very tough time raising their arm actively up, reaching behind the back, or I'll see as I isolate the rotator cuff on physical examination, there will be pain and weakness. So just a couple of things that if I saw you for shoulder pain and I was concerned for a rotator cuff problem, these are some of the tests that I would perform to better identify the problem that you have and see if the rotator cuff might be inflamed. So near sign is when I would push your shoulder forward, and that essentially causes the one of the tendons of the rotator cuff to rub up against the bone, the acromion, and that causes pain. There's a classically described sign called the Hawkins sign, where when you internally rotate the shoulder out like this, and put that causes pain when the rotator cuff tendon is pushed against bone. There's specific tests that I would do to trigger or activate, or these are called provocative maneuvers, meaning if we test the rotator cuff and activate it, if there's pain, that to me leads to suspicion for a rotator cuff problem. Again, this is testing rotational strength. So normally you should be able to hold the shoulder against, with your elbow by your side. And if I push against your shoulder, you should be able to give resistance. But if you can't and you have weakness, that's a sign of rotator cuff pain. And this is another test kind of isolating the teres minor, which allows you to go from this position to this position. And if you have pain doing that, that's a sign of a teres minor tear. Now, one of the more important tendons of the rotator cuff is the subscapularis, the one that sits in the front. And that allows you to kind of push your hand off your back or internally rotate the shoulder. And when you test these functions and there's significant pain or weakness, that triggers me to think about rotator cuff, the subscapularis tear. And finally, so this image demonstrates a full thickness tear compared to a partial thickness tear where it involves the entire thickness of the tendon. And if I have a high suspicion for a full thickness tear, especially if you had an injury, I would get an MRI, and this is the MRI that shows this is the rotator cuff muscle, this is the tendon coming in, and the normal appearance on this type of MRI, it should be this dark structure here is what the tendon should look like. But here we see as we come further down that the continuity of the tendon has been lost, and you have this space that lights up as this white fluid, and that's an indication of a full thickness rotator cuff tear. So as I'm treating patients, I'm thinking about rotator cuff problems in kind of three different groups. So the first group is where a patient has the rotator cuff is largely intact, but there's really just tendinitis, bursitis, or tendinopathy. There's no true tearing or a partial thickness rotator cuff tear. That's kind of a low priority, something that we can try non-operative treatment, and I'll go into what that is. The second bucket of patients is when you have a patient that comes that fell or was lifting something heavy, and all of a sudden, then they experience sudden pain, can't raise their arm. So that's called a traumatic tear, a tear caused by an actual injury, or tears that are full thickness on MRI that are larger than a certain size, 15 millimeters, or someone that has a known rotator cuff tear that's been seeing me that then all of a sudden that we were treating without surgery, all of a sudden had a recent loss of function. So that makes me think that that tear just got larger. And then the third, so that's my kind of high priority group, that group 2. And then group 3 is the people are patients that have large, massive tears that have been there for a long time, or older patients, even with acute traumatic rotator cuff tears, where surgery is not necessarily our top priority. So groups 1 and 3 rather, this group and this group I would commonly treat with non-operative management, and group 2 is surgical. So there's many different ways that we can manage rotator cuff problems, and I think there's not all tears are the same, and each patient, each tear type is different to me. And after examining patients, getting to know them, knowing their activity levels, if they're right-handed or left-handed, what their jobs are, what their activities that they like to do, what their hobbies are, I can tailor a plan for each patient individually by following research-based guidelines. So, non-operative treatment for rotator cuff tears, we can give oral medications, activity modification, cortisone shots, and physical therapy. With physical therapy, goals are to restore pain-free motion and in a way strengthen the muscles that are intact, so you can offset the deficiency of whichever rotator cuff might be torn. So the oral medications we talk about commonly are the NSAIDs, non-steroidal anti-inflammatory drugs, and those are available over the counter: Advil, Motrin, Aleve, Celebrex. One that I like to prescribe is meloxicam or Mobic, which is very easy to take for patients because they only have to take it one tablet once a day after eating. But the advantages of doing anti-inflammatory medications is pretty easy to use, and it helps with pain and inflammation. The disadvantages are the side effects. There's certain patients that are not supposed to be taking NSAIDs because of other underlying medical problems, or more commonly gastritis, that their stomach can get upset. So patients are reluctant to take. Sometimes they're not that powerful, so you have to take the medications frequently. Injections are, if my first round of treatment is usually oral medication with physical therapy plus or minus an injection. And the goal of the injection, so all of the shoulder injections that I do for rotator cuff problems include cortisone, which is an anti-inflammatory medication, as well as a little cocktail of numbing medications that can decrease the pain. So the goal is to decrease pain, and more important is the decreasing inflammation. So the cortisone is the key ingredient to that cocktail, And by decreasing the inflammation, we can decrease the pain and potentially improve function by just doing a cortisone shot. Now, the advantage of that, it's effective in the short term, and it's really medication delivered right to the area that's problematic. But one of the disadvantages or potential disadvantages, if it's done too frequently, is it can potentially weaken the tendon and even damage it. So, and also long-term efficacy is very unpredictable. How long the duration of the improvement is. So, patients ask me, hey, how long do you think it's going to last? And I always tell them, you won't know until you try it. It might be a week, it might be 2 weeks, it might be 3 months, it might be all you need to get past your problem to a functional level. Physical therapy, as I mentioned before, the goal of physical therapy is to essentially restore your motion and kind of strengthen the muscles that are intact to kind of compensate for the ones that might be damaged. Now, if someone comes to me, we've tried physical therapy, we've tried anti-inflammatories, we've maybe done an injection, and things are not progressing along. An MRI showed a full thickness or even a partial thickness tear. The standard of care for rotator cuff tears is arthroscopic rotator cuff repair. If you know anyone or you go to someone that does an open cuff repair, those are more the older school physicians, but not that it's a bad thing. There's some people that have a great outcome, but I think at this point, most surgeons should be doing an arthroscopic rotator cuff repair. And I'll show you how that's done. This video is pretty cool. So this is
the Arthrex Speed Bridge is a soft tissue fixation device that combines fully threaded swivel lock anchors with
shoulder model, and there's we make small incisions around the shoulder and put these cannulas or portals to be able to access the shoulder from the outside without making any large incisions. And essentially what we do so here we see the rotator cuff tear, this crescent shaped structure, and essentially this piece, this tendon needs to be brought back to its native location, and we do that by first roughing up the area of bone that we want the tendon to heal to, and then we use suture anchors. So these are essentially biocomposite or some sort of plastic that we place into the good bone of the shoulder, which has suture attached to the anchor. So the suture is held in place, and then we take that suture material and sequentially pass it through the rotator cuff tendon to essentially be able to pull it back to where it belongs. And there's now knotless techniques where we don't have to tie knots, but in general, the original, described methods where we essentially tie down the tendon using knots. And this is a nice little knotless technique, which I commonly use. And you'll see as we progress forward that we retension the shoulder and bring the tendon back down to where it needs to be and secure it further with these two other suture anchors. The representation, there's another passage of suture, and that's incorporated into another anchor, and it's dunked into bone, and that essentially brings the tendon back and holds it together until, so this is this is a nice repair construct, but that doesn't mean that that's the end of the story. So rotator cuff repairs are, some of the, I always caution my patients, look, you're ready for surgery, but it's painful recovery. So the first 2 weeks you're in a sling, not doing anything. You have a lot of pain because of the fact that we do this arthroscopically and we stretch the soft tissues as we do the surgery so that we can do this arthroscopically. We put fluid in the shoulder, and that stretch of the tissues leads to significant pain for the first couple of weeks. But after the repair is done perfectly, the tendon still needs to heal down to the bone. And for that reason, we protect the shoulder for 6 weeks without any significant range of motion, particularly active range of motion where you're using your muscles to move your shoulder. And then, everyone has their own different therapy or rehab protocols. But as long as it's followed to the T, I think you can have a very good outcome. Now, there's patients that have large, massive, irreparable rotator cuff tears, especially older patients. And in that case, we use a shoulder replacement. That's the best treatment options for irreparable rotator cuff tears. If we have let's say somebody tears their shoulder rotator cuff tear today, and 10 years later, they didn't have any surgery, they didn't do anything for it. As time goes on, the tear can enlarge and it kind of contracts and scars where even if I tried, I can't get that tendon to go back to where it belongs. And in that case, the right answer is a shoulder replacement. I can commonly identify irreparable tears on an X-ray or even on MRI, where the quality of the tissue is different. The humeral head, the ball is migrating up because it's been there's been a long a chronic rotator cuff tear, and I can identify those on X-ray and make the right decision for patients. This is what a reverse total shoulder replacement looks like, commonly done for patients with arthritis with underlying rotator cuff problems, but can also be done primarily for irreparable rotator cuff tears. So again, as I mentioned to you before, there's 3 kind of groups of patients for me, and group 2 is where I would consider surgery soon, within 3 months of when I see patients. But if you're in group 1 or group 3, time is not of the essence. But traumatic tears, so if you had an injury, you want to get diagnosed quickly. If you didn't have a fall or lifted something heavy and you're having pain that started out of nowhere, it's okay to take your time, do physical therapy, do anti-inflammatories, consider an injection. And if all of that doesn't work, getting an MRI to see what if there's a full thickness tear and fixing it is not an unreasonable option. But group 2 is where time is kind of, I'm a little bit more aggressive in this group of patients. And so, you need to think to yourself, did I have a traumatic injury, or do I have slow, insidious chronic pain with activity, pain at night that bothers me all the time, difficulty with overhead activity or reaching behind the back? Do I have any weakness? These are all kind of concerns, all things that would concern me about a rotator cuff problem. And if you do, come on and see us. This is a view of our office, actually, right? You can see in the back, I'm sitting in my office here, and this is the view we have, which is a nice little perk of working here. But if there is a concern, please do make an appointment to see us, and we'd be happy to kind of take you through an examination or diagnosis, and if needed, get an MRI and talk about treatment options. So with that, I'm going to kind of open the floor for questions.
And again, just a reminder, if anyone has any questions, you can either type them into the chat box or you can type them into the Q&A.
I don't think I could see any of the questions, right?
I'll read them out to you, no worries.
Okay, yeah, please.
We don't have any questions just yet, but I'm going to give it a minute or so.
Sure.
Here's a question. Can you see a tear in an X-ray, or does someone need an MRI?
So that's a very good question. Most often, you can't see a rotator cuff tear on X-ray. So X-rays are a screening tool for me to make sure there's no fracture, to make sure there's no underlying arthritis. So on X-ray, we could see bony structures. So essentially the ball, the socket, the collarbone, the shoulder blade. We cannot see rotator cuff. We can't see soft tissue. But if there's a massive rotator cuff tear that's been present for a long time, I can identify subtle incongruity of the joint surface where the humeral head is riding up. And I can see that on an x-ray and kind of identify a rotator cuff tear, but that's relatively uncommon. Almost always, in order to diagnose a rotator cuff problem, an MRI is needed. But I like to do x-rays first to make sure there's no arthritis or underlying fractures that need to be found before progressing to straight up getting an MRI.
Thank you for your answer. The next question is, are there some basic preventative exercises someone can do to keep their rotator cuff optimally functioning?
Is this like a profile, meaning before there's any pain, are there things that you can do to strengthen your rotator cuff, or like a preventative?
Yes, preventative exercises.
Not quite. It's funny because one of the surgeons that I trained under was a physical therapist, and before he became a shoulder surgeon, and now he's a world-renowned shoulder surgeon. But he would commonly get this question. He's like, "Well, I wish there was an answer, but I used to be a therapist, and there's truly not a true preventative mechanism to prevent rotator cuff disease. Sure, you can isolate the rotator cuff and strengthen it, but that I don't think is preventative. There's no real research that shows that that's preventative."
All right, the next question I have is a two-part question. After rotator cuff surgery, how long does it take to heal? And should physical therapy or other treatments be used to promote healing?
Yes, another good question. So I tend not to start physical therapy too early. And so, as I mentioned, after I do surgery, I want that tendon to heal to the bone. And the critical period during which that takes place is the first 6 weeks. So the first 6 weeks, I really don't want a patient or a therapist accidentally starting to move that shoulder by actively firing the muscles. When I say active range of motion, that means, if I am moving my shoulder without anyone's help, I'm using my muscles. The muscles contract and they're able to raise my arm up. I don't want patients doing that after rotator cuff surgery for the first 6 weeks. On the other hand, if, let's say a therapist or the family member of the patient, for example, to clean under the armpit, takes the patient's arm and lifts it up for them without the patient helping them, that's acceptable. That's passive range of motion, meaning that the range of motion is occurring without an activity of the muscle. That is safe, and that I encourage that. But I would not. So long story short, or long answer shortened, I see patients back at 2 weeks, and I let them do certain exercises, and I teach them the exercises in the office that I want them to do. And then at 6 weeks is when I get them plugged in with therapy. The reason for that is two. One is there's only two major exercises I want patients to do that are safe. And number two, recovery after rotator cuff injury or surgery rather is a long process, and that's going to require numerous visits for physical therapy. And I don't want my patients to run out of physical therapy visits from an insurance standpoint. So if the first 6 weeks I can teach them the basics, then they can actually have skilled physical therapy for the time that really matters, the 6 weeks and onward. So I don't want them to run out of physical therapy visits. So I teach them the exercises in the office the first couple of weeks. And I think that dramatically improves patients' function when I'm teaching them the exercises rather than a therapist that may not kind of emphasize certain things. So I take pride in educating my patients, not only before the surgery to what to expect, but also guide them through the recovery that's safe and effective.
Thank you. The next question we have, currently no shoulder pain, but when I go to the gym and work on the shoulder machine, I have pain in the left shoulder. Is that a tear?
So activity-related pain, but again, that's something that's very difficult to identify just based off, age matters, hand dominance matters. What are the activities that, besides the gym, what functional activities are limited? you able to lift your arm up? Are you able to reach behind your back? Are those have those problems been there, and is this pain coming back, or is it the first time? Did you have an injury? There's a lot of things that are missing in this scenario. So I'm happy to, if you provide more detail, maybe I'll go through some things, but it's hard to tell. You might have a tear, unfortunately.
The next question is, can an injury to the shoulder also produce pain to the area under the bicep?
Yes, so rotator cuff problems, either tendonitis, bursitis, or rotator cuff disease, is commonly, people describe it in the back of the shoulder over here, but it also radiates down into the arm, but it rarely goes past the elbow into the forearm. In fact, it usually never does. And that's an important question I ask patients, because I see three types of patients in my office: people that have truly just shoulder problems. And so most shoulder pain is here and it radiates down, but it stops before the elbow. A second group of patients I see is people that complain of shoulder pain, but their problem is really in their neck. So if you have a cervical, a disc herniation in the neck or arthritis in the neck, nerves that are exiting the spinal cord are inflamed or damaged, that can be perceived by our bodies as shoulder pain, but the true problem is not in the shoulder. And what triggers me to believe cervical spine-based pain is patients commonly complain of numbness and tingling in their fingers. They have pain in the back of the shoulder blade that kind of radiates down the arm in a stripe-like pattern, all the way down past the elbow into the forearm, into the fingers. And to me, that's classic cervical spine pain. And I just make sure that the shoulder range of motion is good. There's no pain with provocative testing of the rotator cuff. And I can commonly kind of tease that out. And the third group of patients is where there's actually shoulder pain, but it's coming not only from the shoulder, so true shoulder pain, but also cervical spine pain. And those are a little bit more challenging patients to take care of because they have two kind of pain generators. And to me, the goal of treatment and diagnosis and treatment is to really identify how much of the pain is coming from the neck versus the shoulder by a combination of injections, MRI of the neck and shoulder, and kind of identifying how much pain is improved with the injection. That's how much pain is coming from the shoulder versus whatever is left over after an injection is likely coming from the neck. So, but that's a very long drawn out answer, but yes, shoulder pain can radiate down into the arm, but if it's truly coming from the shoulder, it shouldn't really radiate into the forearm or the hand or cause numbness and tingling.
So the next question is actually very similar to the question that you just answered. So we may have already answered their question. Can a tendon tear cause muscle pain between the neck and shoulder?
It can, but if we're talking about it between the neck and the shoulder, like in this region, the trapezial region, or the shoulder blade area, the scapular region, commonly if I see pain in those areas, it's very likely cervical spine based, but that doesn't mean that there is not also a rotator cuff problem. So that's something worth getting looked at. Now, a common thing that occurs not with rotator cuff problems is arthritis in the collar, the joint between, I'll pull it up here, the collarbone so this joint, so this joint right here between the collarbone and the acromion is the acromioclavicular joint. And oftentimes when there's rotator cuff problems and biceps problems, there's also arthritis in this joint. When you have arthritis here, it's tender to touch right on top of the shoulder, and it can also radiate into that part of the neck. And so that may be a sign of AC joint arthritis.
The next question I have, how long is the recovery period after surgery?
So typically the first 2 weeks are relatively painful because of the surgery itself. And as time goes on, pain improves. You have less bad days. I tell patients you'll have fewer bad days, more good days. As I mentioned, the first 2 weeks, very little motion I want. And then as we progress in time, the first 6 weeks are critical for the tendon to heal to bone. At 6 weeks, I start with physical therapy, allowing for active range of motion without any limitations. And then usually by the 3 to 4 month mark is when most patients feel they're doing significantly better and they're kind of almost healed. So it varies, but I usually estimate 3 to 4 months of recovery process. And you continue to make progress as, you know, at 3 months is when I start strengthening, and you continue to make progress over the period of even as until 6 months. But 3 months is a key period for most patients.
And the final question I currently have in the chat box is, can acupuncture help alleviate the pain?
So there's no, to my knowledge, there's no research basis for using acupuncture, but anecdotally, I have a lot of patients that come to me with shoulder problems, and they've done cupping, they've done acupuncture, they've done non-traditional methods and have noticed improvement. So it's not unreasonable to try it. But from a evidence-based standpoint, I don't know of any studies that have shown that to be effective. One thing I didn't comment on, and a lot of patients have recently been asking about, is the use of orthobiologics to enhance healing. So people hear about stem cells, platelet-rich plasma, amniotic fluid, and you know, it's a more common question, but it's been around for many years. There is some evidence that does demonstrate, you know, rotator cuff problems can be potentially improved with platelet-rich plasma. The goal is to regenerate the tissue to a point where healing occurs. I don't think that it makes sense to do that in a rotator cuff tear that's full thickness tear, but there may be a role for that in partial thickness tears. The kicker really is that insurance companies don't cover it. So it's a cash out of pocket expensive treatment modality. And there's a reason for that, is because there's not enough research that shows that it is effective. So once the research is there, and I think it's just not there yet, there will be more and more insurance companies covering that. And that may be a more common treatment modality prior to doing surgery. But that, I think, also should be done in select patients, not every single patient. Even more, you know, more so in patients that are diabetic, that have an impaired, healing capacity. I think that's where it'll be. You know, I do use it in the revision. So there's a patient I just spoke about yesterday that had a rotator cuff surgery, I think about 6 years ago, done elsewhere, and it's retorn now. And so when we're talking about a revision rotator cuff repair, I commonly bring out everything I can. So bring out all my ammo. And so amniotic fluid, platelet-rich plasma, all these things now come on the table for me to augment my repair with these biologic adjuncts. But certainly I wouldn't do it on everyone. There's people that are doing it on everyone. I just don't know if there's truly enough research that shows that. But it certainly adds cost. And in this day and age, you need to be cost effective as well as being a good clinician. So that's something that I didn't discuss purposely and intentionally, but there's patients that ask about that, and I just want to shed light on that.
Thank you so much for answering the questions. I have no more questions in the chat box or in the Q&A. So I just want to say thank you very, very much, both to you, Dr. Maida, and to Nikki, for organizing and attending this wonderful session. We really appreciate you guys being here. And I also want to say thank you to everyone who came this evening. Thank you so much for spending this evening with us and for attending this program.
Excellent. Thank you very much for having us. And I look forward to taking care of anyone that has any problems with their shoulder or elbow in the future. Have a good night.
Dr. Maida, good night, everyone.
Have a wonderful evening, everyone.